The passive absorption of any drug relies entirely on one physical requirement, a concentration gradient. Molecules naturally move from high to low concentration, but in a closed environment, this downhill transport has a strict thermodynamic limit. As molecules cross the barrier, the system moves inevitably toward equilibrium. Once the concentration equalizes on both sides of that barrier, net movement halts entirely. If this occurred inside the gastrointestinal tract, systemic drug absorption would drop to zero. To build up a therapeutic level of medication in the bloodstream, the human body must actively and continuously prevent this equilibrium from taking hold. It achieves this through a specific biological engine known as the Fick condition, a physiological mechanism that overrides standard diffusion to keep the transport gradient running strictly downhill. Without this Fick condition, oral administration of pharmaceuticals would be mathematically useless. The absorption process would stall out at equilibrium long before a full clinical dose could reach your tissues. To see exactly why a closed system fails, we have to look at the mathematics governing passive transport across a biological membrane. This is Fick's first law of diffusion. It calculates the rate at which a drug moves into the blood over time. The numerator contains three fixed variables: the surface area of the absorbing membrane, the diffusion coefficient of the drug, and its lipid-to-water partition coefficient. These are static physical properties of the specific drug and the gut itself. The denominator is the membrane thickness, which is another fixed biological constant. With those physical constraints locked in, the rate of absorption relies entirely on a single dynamic term, the concentration gradient. This term represents the difference between the drug concentration in the gut lumen and the drug concentration on the other side of the wall, in the local plasma. In a closed system, every molecule of drug that successfully crosses into the plasma increases that local concentration. This rising plasma value subtracts directly from the concentration in the gut, forcing the total rate of diffusion to collapse towards zero. If the local plasma concentration is allowed to rise, the mathematics dictate that absorption will stall out, no matter how highly permeable the intestinal membrane is. This mathematical collapse is avoided by shifting our focus past the gut lumen, directly into the capillary beds on the basolateral side of the enterocytes. Here, splanchnic circulation acts as a high-speed transit system, violently sweeping absorbed drug molecules away from the local membrane the exact moment they arrive. The drug is immediately pushed into systemic distribution, diluted across a massive physiological volume of blood and peripheral tissue. Looking back at Fick's equation, this constant vascular clearance means the plasma concentration immediately adjacent to the absorption site never has the chance to accumulate. This creates the formal definition of the Fick condition. The concentration of the drug in the gut remains vastly greater than the concentration in the local plasma. Mathematically, this vascular clearance forces the plasma variable to become an effective zero. The subtraction penalty is completely removed from the driving gradient. Vascular perfusion acts as an infinite biological drain, permanently locking the transport system into a state of maximum thermodynamic drive. With the plasma penalty physically eliminated from the equation, the entire mathematical model changes form. In this modified Fick's equation, we consolidate the fixed physical constants: the surface area, the diffusion coefficient, the partition coefficient, and the membrane thickness. These static properties are grouped together into a single unified operational metric known as permeability. The equation collapses down to a simple multiplication problem. The rate of diffusion equals permeability times the concentration in the gut. By establishing Fick conditions, the body forces a complex bidirectional diffusion process into straightforward, apparent first-order kinetics. The rate entering systemic circulation is limited by two factors: the drug molecule's inherent permeability and concentration inside the gut. The Fick condition operates as a mathematical override, transforming a self-limiting biological hurdle into a highly predictable, linear pipeline. Before membrane permeation can even begin, solid oral dosage forms face an entirely separate, critical rate-determined step: dissolution. This is the Noyes-Whitney equation. It models the rate at which a solid hydrophobic drug dissolves into an aqueous fluid, and it relies on the exact same principles of diffusion. Just like Fick's law, it is driven by a concentration gradient. Here, it is the difference between the saturation concentration directly at the surface of the pill and the concentration of the bulk fluid surrounding it. This split-screen model illustrates why laboratory testing often fails to predict human absorption. When a tablet dissolves in an in vitro beaker, it operates in a non-sink condition. As the drug dissolves, the bulk fluid concentration rapidly rises. As the bulk fluid saturates, the concentration gradient shrinks, eventually stalling any further dissolution of the solid tablet. Now look at the in vivo environment. Inside the human gut, the dissolved drug doesn't just sit in the fluid. It is continuously absorbed across the gut wall via Fick's sink condition, meaning the bulk fluid concentration is constantly drained, remaining near zero. If the surface area of the solid and the volume of the fluid remain constant under these in vivo conditions, the complex dissolution rate simplifies entirely. It converts into a clean, pseudo-zero order kinetic rate. Raw in vitro testing fails to predict true systemic bioavailability precisely because a static laboratory flask lacks the continuous vascular drain of a physiological sink. These mathematical models dictate the ultimate metric of clinical pharmacokinetics, bioavailability, which calculates the exact fraction of a dose that reaches the systemic circulation intact. Looking specifically at the fraction absorbed, we find the total proportion of intact drug that successfully crosses the intestinal epithelium. Maximizing this fraction requires a drug to execute both rapid dissolution from its solid state and highly efficient permeation through the lipid bilayer simultaneously. Both of those rate-determining processes are entirely dependent on the sink condition acting as their invisible driving force. By formulating drugs for rapid dissolution or adjusting for a patient's altered splanchnic blood flow, clinicians are directly manipulating the sink to dictate systemic absorption. The body's vascular sink operates as the master controller of passive pharmacokinetics. It ensures that pharmaceuticals enter the system as a continuous driving flow, overriding the natural physical laws that would otherwise trap them at equilibrium.